Yes, I'm Tim Bickmore at Northeastern in Boston, and I'm going to be talking about virtual agents and their use for substance use screening, brief intervention, and referral to treatment. So this is work performed at the Veterans Administration, the U.S. Veterans Administration Medical Center in Boston. My collaborators on this work are Stephen Simon, who's a general internist, now in Los Angeles, and Amy Rubin, who's a psychologist who specializes in substance use interventions. So substance use in general and alcohol misuse are a problem in the general population, but within the population of US veterans, it's especially a problem. Studies have shown that up to 40% of veterans have problems with drinking. And studies have shown that there's a huge unmet need for treatment as well. So one study among veterans returning from Afghanistan found that although 18% met the criteria for alcohol use disorder, only 2% were receiving treatment or had received treatment for their problems. So it's been long recognized that an ideal site for intervening or helping veterans with alcohol problems is in primary care, when they come in to see their primary care physician or PCP for their annual checkup or for any regular meetings. This is an ideal time to screen them to see if they have alcohol problems and then to provide brief intervention to try and help them or refer them out to psychologists for specialty follow-up. So this has led the Veterans Administration to enact guidelines that indicate that veterans should get screened every year on alcohol problems. And if there are problems, to provide this brief intervention or referral. However, many veterans don't actually receive this screening, or if they do, the brief intervention is not performed or the referral is not given. One of the reasons for this is that substance use in general is an awkward topic to bring up. It's potentially stigmatizing, especially if it involves illegal behavior. So this could be one of the reasons why this doesn't happen as often as it should be happening in primary care. Also, physicians don't always receive the training that they need to perform this brief intervention and screening. So what we have worked on is a virtual agent that can perform this task in primary care. So when you go in to see your primary care physician for your annual checkup in a private room, you could sit down and have an interaction with a virtual agent that could determine if you have substance use problems, provide a brief intervention if indicated, and refer you to specialty care if needed. So there's several reasons why this might work well. Since the agent performs the same way every time, we don't have to worry about it having appropriate training. And also there's now been decades of studies showing that people are more likely to disclose potentially stigmatizing behaviors such as substance use to computers in general and virtual agents in particular compared to humans or even paper and pencil questionnaires. So I'm going to talk about two projects that we did at the Veterans Administration in Boston. The first one is covered in detail in the paper, and that's doing substance use screening by a virtual agent, so determining if there is a problem. So in this work, we picked a particular screening instrument that's widely used called the NIDA Modified Assist. So this is based on the Assist screener that was developed by the World Health Organization and validated in several countries. When the National Institute of Drug Abuse, or NIDA, part of the National Institutes of Health in the US, adopted this, they made some minor modifications, and that's the screening instrument that we use. So it's a paper form that you can fill out. There's also a computerized version of this, but we developed an agent that could administer this using the same verbal strategies that a primary care physician would use in asking these questions. So the virtual agent that we developed is deployed on a touchscreen computer. The agent talks using synthetic speech and synchronized nonverbal conversational behavior, including hand gestures, proxemics, facial display, head nods, gaze cues, and so on. The dialogue is generated using hierarchical transition networks and template-based text generation. User input is fully constrained to multiple choice inputs on the screen. The dialogue was designed again to mimic what a PCP would say in administering this questionnaire, including clarifications if needed and empathic feedback the individual is expressing problems. And then it would output at the end of the interaction that mirrored the one that the NIDA modified assist would output. So we performed 2 studies to validate how well the screening administration by agent worked in primary care at the Veterans Administration. So in the first study, we compared the agent administering the NIDA modified assist to a human research assistant administering the same form on paper, verbally, the way that it's normally given. And the second study, we compared the virtual agent administering the NIDA modified assist with an older tool that was available at the VA that was actually an implementation of the original assist implement. This was integrated with the electronic medical record system in the VA called the CPRS Mental Health Assistant. And it's a Windows-based forms administration using a graphical user interface. And here's a sample screen from it that they could sit a patient in front of and to answer the different questions on the questionnaire. Both of these studies, again, were done in primary care clinics in a private room. They were both counterbalanced, so we randomized the order of administration of whether the agent went first or second in each of these studies. So in each study, we had approximately 30 participants, again, within subjects' validation study. They ranged in age from 41 to 65, mostly male, mostly Caucasian, and high self-reported computer literacy. The primary validation outcomes for all of those substances in which individuals reported, in which we had at least 5 individuals who reported any use, we demonstrated high correlation between the agent and the comparison group. So in study 1, we saw high correlations between the substance involvement scores found by the agent and those found by the human administration of the NIDA modified assist. And in study 2, high correlations between the agent determination of substance involvement and those found by the mental health assistant. Another question on these assessments is not only how much of a problem do you have now, but have you ever used these substances as a Boolean indicator? And here again, we found high agreement across both methods for both studies, with the one exception of sedatives in study 2. In study 1, 20 of 30 participants had identical responses on both methods of screening. And among the other 10 participants, there were 16 discordant responses between the agent and the research assistant, with a majority of these reporting more substance use to the agent compared to the human, which is consistent with the prior study showing greater disclosure to agents. When we asked people for their satisfaction with the assessment method, in the first study, we saw significantly higher satisfaction with the human research assistant compared to the agent. But in the second study, we found significantly higher satisfaction with the agent compared to the mental health assistant, the standard GUI-based assessment form. So results from this validation study is that it was an acceptable means of doing screening, that veterans had no problems using it, were satisfied with it, and that it had significant agreement with alternative approaches of doing screening. So this study was followed up by another project that was mentioned in the paper, but I was going to go into more detail now. It's a recently completed randomized clinical trial to evaluate a substance use counseling and referral by the agent for substance use. So we extended the agent to perform brief intervention for alcohol misuse once it determines there's a problem. So it first elicit your current drinking behavior by asking questions about that. If indicated, it would perform motivational interviewing, so using ruler talk for motivation and confidence to try and boost motivation for reducing your drinking, empathic feedback, and at the end of the reflection statements, and at the end of the intervention, it would elicit a commitment to change from the veteran. So this was designed as two 20-minute long sessions that would be administered 1 month apart during visits to primary care, again in a private room with a touchscreen computer. So I'll show you a little video clip of what this intervention looked like.
Many people are surprised to learn what counts as a drink. What is important is how much alcohol you consume, which is different based on the kind of drinks you are having. So, different types of beer, wine, or liquor can have very different amounts of alcohol, and mixed drinks can have 1 to 3 standard drinks in them, depending on the recipe. One standard drink would be 12 of regular beer, 8 ounces of malt liquor, 5 ounces of wine, or 1.5 ounces of whiskey or other liquor.
Okay, so we conducted a randomized clinical trial at primary care clinics at the Veterans Administration to evaluate how well this intervention worked. The eligibility criteria for veterans in the study were that they screened positive for alcohol misuse on the Audit C, which is the standard instrument that they use in the VA for annual screening. Also, individuals had to be drinking above the guidelines within the last 30 days, so had a recent problem, and not be in treatment or recently in treatment for their alcohol misuse. We compared the agent with usual care that they received against the usual care that they receive at the Veterans Administration. And usual care consists of this annual screening with the Audit C, and then there's guidelines that indicate if the screening score is above a certain threshold, that the primary care physician is supposed to provide brief intervention, which is basically telling the veteran that they have a problem and recommending that they reduce their drinking. And if the screening score is above a higher threshold, they're supposed to receive referral to specialty care. So these things don't automatically happen, but this is what's supposed to happen according to the policy guidelines. So in the randomized clinical trial that we performed, we had 178 veterans who completed the study, who were randomized either to usual care or usual care with the agent. Again, mostly male, mostly Caucasian. We had, I believe, all services represented, mostly from the Army. The primary results, the primary outcomes from the study were drinking behavior at the end of the 2 months. This is average drinks per day or drinking days per week. We saw significant decreases in actual drinking behavior across both conditions. So all the veterans decreased their drinking, but we did not see significant differences between the agent and the usual care conditions. So the agent didn't do any worse or significantly better than the primary care provider. On a number of secondary measures, though, we did see significant differences. So every veteran who interacts with the agent, of course, receives brief interventions, that is this motivational interviewing counseling. However, for those who were in usual care, based on chart review of their medical records, as documented by the primary care physicians, only 44% received brief interventions of those who should have received brief interventions. And for referrals to specialty care, in the standard care group, only 1 veteran received a referral, whereas almost 25 in the agent condition received referrals. So this was a significant difference as well. One of the secondary measures was called the SIP, which assesses how much of a negative impact is alcohol having on your life recently. And we saw significant reductions in this measure in the agent group compared to the standard care group. So in conclusion, again, on the screening study, we were able to demonstrate validation of the agent-administered screening for substance use compared to 2 alternative methods. And in the randomized clinical trial, we demonstrated the feasibility of doing the intervention in primary care in the Veterans Administration. The agent did as well as a primary care physician at reducing drinking behavior, although it did not do significantly better. And on several secondary measures, including number of brief interventions conducted, referrals to specialty care and drinking consequences, the agent did significantly better than standard care. Thank you. I'll take questions.